Good morning and welcome to our public board meeting for Northamptonshire Healthcare Foundation Trust, and it's Thursday the 28th of May. And for those who have not met me before, I'm Faisal Hussain. I'm the interim chair. So welcome to all our colleagues, governors, members of the public, and also our staff who might be observing this meeting. Just to remind everybody, the meeting is being recorded and live streamed, and the recording will be made available via our public website. Just to take apologies, we've got apologies from Anne Rackham, and Adam Smith is here to deputise, and we also have an apology from Paul Sheldon, our Director of Chief Finance Officer, and Janine Joseph is here to deputise, and also we have apologies from David Williams. Are there any other apologies that I need to be made aware of for our minutes that I've not already been made aware of? Nope. Okay, great. And then in terms of our agenda, any declarations of items in relation to today's agenda that have not already been captured in our declarations and register of interests? No. Okay, great, thank you. And then we have in your packs paper A, which is the minutes of the meeting held on the 26th of March. First of all, in terms of accuracy, colleagues will have had an opportunity to review those minutes and make any amendments or changes that were required. Are you happy in terms of accuracy so we can sign those minutes off? Yep, I'm getting nods and a few thumbs up, thank you. In terms of any matters arising that are not captured anywhere, anything that anybody wants to raise? No. Okay, great, thank you. And then paper B is our action sheet. There were no actions that were required to be carried forward and outstanding, so that's also noted. And then we move into the kind of one of the opening parts of our board meetings always is having a service presentation. And today we've got the mental health and learning disability and autism pathway, which is around the lived experience of the Oliver McGowan co-trainers and the Recovery College. And for that, I'm going to hand over to Adam. Adam, over to you.
Thank you, Faisal. Hopefully everybody can hear me, and hopefully you can see the start of that slideshow. There we go. Okay, brilliant. Thank you very much for the confirmation. Good morning, everyone. As Faisal said, I'm Adam Smith. I'm Director of Mental Health, Learning Disabilities and Autism for the Trust. And I'm really grateful for the invite to be here to talk to you about our learning disabilities services this morning. I'll take you through our services in brief, and then I've got a really wonderful video from one of our lived experience experts who also supports us with the Oliver McGowan training that I'd like to show you at the end of that. But I thought it important to take a bit of an opportunity, if that's okay, just to update you on my contact with you last time. So when I came to board previously, I presented, for those that might remember, on the memory assessment service. And this was a service that we're trialling a new way of working in Corby, the diagnostic centre, looking at reducing their wait list for dementia diagnosis by having a same-day service for MRI scans and blood tests to try and improve efficacy and efficiency of that and improve the patient journey. And I'm really pleased to say we had the outcome of the evaluation from the Carers Trust just at the end of last year, and that was phase 2, which was between October and December last year. And they recognised that the second phase of the Diagnostic Centre for Dementia Pathway was a pilot model that was capable of delivering faster, better and coordinated, more compassionate diagnostic journey for people with suspected dementia and their carers. And in that period, there were 111 appointment slots available. And I think what was really key to the efficacy is that 91 patients attended those slots. So it's an 82% attendance rate, with that ability to have that 2-week turnaround on all of those diagnostics and assessments. And the other thing that was really key in the evaluation, which I think was important to the benefit of the partnership working that comes from activities like that and the way it had been developed, was that referrals into both Northamptonshire Carers and the Alzheimer's Society were at 89 and 90 of those 91 people attended. So that was people that were pre any social care assessments or any other formal assessments through the process of getting a diagnosis, were getting that early help, signposting, and support through their families and themselves as individuals, right from the point of being in contact with that diagnostic centre. So I think that's a huge achievement to the team and really demonstrates that partnership and that difference in way of working. The team currently now are working on a version in the west of the county, looking at using space at Kings Heath and the Watermill Centre at Berrywood. They're both within 10 minutes of each other, so that same day approach can still be worked through, and that's ongoing with a hope to go live for that in July. So I just wanted to bring that back and just feedback on that for you, because I think it's a lovely kind of rounding off to that presentation that I brought last time. I can't seamlessly segue that into learning disabilities, I'm afraid, but I am really pleased to be able to bring to you a discussion around our current learning disabilities services, which over the last probably 5 years have had a greater focus, and 10 years or more following kind of Winterbourne View and concerns around the care that's received by people with learning disabilities and or autism across the country. Our learning disability services have made huge changes in the way they deliver their models of care, how they manage crisis, how they manage hospital admissions, and then how they get people out of hospital and back into community and their homes for life. And there's some really innovative work that's happening. Let's see if I can get you through the slides. So LDA services as a whole are a fairly large resource in the county from an NHFT perspective. So we've got a group of services that provide specialist health and support for adults with learning disabilities and autism and complex clinical needs. And then elements of our service also work with children through, so our community service for people with learning disabilities also works through child issues as well. So they perform that transition through services. It's here we go. So learning disabilities services are always brilliant at providing infographics for service users and carers that really clarify exactly what they deliver. And this is a wonderful example of top left, the services that we deliver. So you've got the community team for people with learning disabilities, and I'll run through these a little bit more in a minute just to give you some examples. You've got the children's team, as I said. You've got an intensive support team, so they're within Reed, almost your crisis team. Your transforming care team, which specifically they're commissioned to support those people who are in hospital or going into hospital to ensure that their journey is as smooth as possible, and we'll talk a little bit about that. You've got your LD and autism swift response team. They are an adjunct to the intensive support team, and then we offer One Willow Close, which is a respite service for people with profound learning disabilities and who need that care and support. As we said there, the team is a genuine multidisciplinary team. It's an incredible mix of wonderful therapists, nurses, psychiatrists, psychologists, and other allied health professionals who take a really holistic approach to the way that they support in a huge range of conditions across physical health issues, mental health problems, issues relating just to the learning disability itself, and then behavioural challenges and the like. And they work as much with the individual as they do with the families, carers, and or supporting providers as well. So they have a real diversity in the way that they meet the needs of service users and carers. The community team for people with learning disabilities, as I said, is that adults and children specialist team. It's the community mental health team version in learning disabilities, but actually probably much broader in that they also have a key agenda around the management of physical health and physical health checks and alike that go with, unfortunately, the poor outcomes of health that we know for people with learning disabilities and autism and the life expectancies. So they have a role in supporting GPs and linking in around that, and implementing the outcomes of the learning from deaths reviews that occur, and we'll talk a little bit about that. Stomp and Stamp is an agenda around medication management and the use of mental health medications in learning disabilities, and a drive to reduce that as much as possible in this group because of its lack of efficacy, but I guess the impact on the physical outcomes as well. But a very multifaceted team. The intensive support team, as I suggested, is again a multidisciplinary team. They work predominantly with providers, so carers or paid carers and paid professional providers who are supporting people with learning disabilities in the community, and their focus is around behavioural support and risk management. So as somebody perhaps moves into crisis or becomes perhaps unwell or dysregulated, it's that team that will wrap around that provider and provide that expert support to maintain and stabilise that placement and provide the interventions around behavioural support to improve that care and ensure that we're moving away from any breakdown in placement, but any crisis admission. The Community Swift Response Team is an adjunct to that. It came a few years ago when we were looking at how we could improve service offer and also just bolster that prevention of admission in crisis. And the Community Swift Response Team, in effect, adds that element of service user engagement much more. So we can provide an adjunct to that professional care. So we can put our own carers into those providers. We can put our own carers into those family environments and support with that crisis period, again, as another way of preventing hospital admission and another way of driving down that need to, or that risk of placement breakdown. The Transforming Care Team, in a way, oversees all of that. So the Transforming Care Team is a team that have been commissioned by NHS England, I guess, across the entire country to look at where we know there are huge issues with people who have been in service users have been in hospital for an incredibly long time with learning disabilities, where either we need to challenge the provider network in the community to make sure that we can provide homes for life for these individuals that are much more suitable to their needs, but also to move away from the long-term segregation and hospitalisation of people with learning disabilities. And this will become more and more important as we see the changes in the Mental Health Act coming through, and we see other issues in providers. They work incredibly hard to both engage at a very personal level with the service users and their carers to really understand their needs and then find the most appropriate placements coming out of hospital, whether that's the most appropriate provider or whether we need to commission and build a home. And this is very much a piece of service delivery that is county-wide and needs us to have really good links with our adult social care colleagues and other providers within the county to ensure that we get that really smooth transition. One Willow Close, and you'll see in brackets I've put CQC Good because really pleased that they achieved CQC Good rating at a recent inspection, and they are a 6-bedded respite unit. I would urge anyone that wants to do a service visit at any point to go and see them. They're absolutely wonderful. The team are an incredibly skilled group of professionals who offer the most compassionate support to a group of service users who have incredibly complex physical and behavioural needs, who really relish the time that they spend at One Willow. And I know that families are incredibly pleased with the support that they get from that service. So it's a really broad range of services. I'm really lucky that I also have a role within the Mental Health Collaborative, so the MHLDA Collaborative, and I chair the Mental Health Transformation Pillar. And I think one of the key things for me when we've talked as a group in NHFT about learning disabilities and autism is that for me the autism part doesn't necessarily just sit with learning disabilities. In fact, it's unhelpful that it does at times, because there are many autistic people who function incredibly well across all of our community services, across our physical health services, and who work within our organisation as well. And I think it's time to progress how we think about that diagnosis and how we work with it. We've been talking at our most recent transformation pillar meetings, which are co-delivered with experts by experience, but also include members from EMAS, the ambulance service, the police, adult social care, our acute colleagues. We've been talking about using something such as the SPACE framework across the entire county as a regulatory framework for us all to think about how we engage with people who are autistic or who have neurodevelopmental needs when they come into contact with our services. And I'm really pleased to say the uptake on this has been fantastic through the pillar. Really energised that all of those organisations are interested in taking this SPACE framework through their organisations to think about how they engage with people with autism right from that first point of contact. And just so you know, so that the SPACE part is that sensory, predictability, acceptance, communication, and empathy, and it's a range of metrics that organisations can think about as to how they might deliver the sensory needs of an individual, how they might predictably deliver their service in a way that has the least distressing impact on that service user when they come into contact, how they can work to accept the needs of that user, listen to that user's voice and those carer voices, and then work in a communication method that is suitable for that user and really adjusts the way they work, and also takes into account that this myth, that there's a broad myth that people with neurodevelopmental difficulties struggle to empathise in situations, and actually that's not true. More often than not, they empathise so much that they struggle with that as an output. So it's a brilliant opportunity across the county, and I'm really pleased to be able to work in that space. And I think this for me was key. It's so important, and it talks to why we do the Oliver McGowan training, which is the video I'm going to show you, and it talks to the importance of the work that the LDA service do. This is the 7th LEADER annual report. So this is the lived experience, learning from deaths report, and it's 2022 because the reports come out and then they're reviewed regionally and then they're reported back to us. And this was the one that was reported back last, which is the 24-25 report. So I guess, you know, tragically there, the mean death being 62.9 and 42% of those deaths being deemed as unavoidable. And these are perhaps routine things that you or I or others might feel that we would receive really good care and support around an early intervention. So cardiovascular conditions, respiratory conditions and cancers, all top of the NHS agenda, all top of the agenda for those and we need to make it so within those people that struggle with their learning disability. People from all ethnic minorities groups died at a younger age, and notably for this period of year when we're suffering with quite a hot period this week, there was a noticeable increase in the notification of deaths during heat waves in that period. And I think telling 110 of those deaths were for adults with a diagnosis of autism and no learning disability. So that's a group of people who should be able to engage with services through the use of models like the SPACE framework and the services we have, and we should be able to manage their physical health needs in the same way that we do any others across our services. So the Oliver McGowan training, I think, absolutely speaks to this. And for those that don't know the why, Oliver McGowan was a young autistic teenager with a very mild learning disability. He had cerebral palsy, and he had autism, and he died in 2016. And it's an incredibly sad case of an individual who just wasn't listened to. His family and he weren't listened to through his experience of care. He was treated via a route of traditional mental health medications and treatments. He was detained under the Mental Health Act. He was at times restrained. All of which it later became apparent was because of a lack of understanding around his behaviours and his needs as an autistic individual and someone with a learning disability. And his mum has has put her life's work following his death into getting Oliver's training into statute. So the government completed a consultation on the Oliver McGowan Code of Practice in 2023, and that's now part of the Health and Care Act, and therefore it is mandatory that all healthcare providers under the CQC provide Oliver McGowan mandatory training. And for anyone that hasn't done it, I recommend you do it because it's fantastic. It's co-delivered, and it's a wonderful way of hearing Oliver's voice and continuing to hear his experience. It's broken down into 2 tiers. So level 1 is a general staff awareness that all staff within NHS and healthcare organisations take on, and it's a 60-minute webinar which is co-delivered, and there's a bit of question and answer within that as well. And then level 2 for all those that provide direct patient contact is a full day's learning in session with a facilitator, and that's joined by a co-trainer who's got lived experience as well. And it's been incredibly transformative. That's our Oliver McGowan training team. They're an absolutely lovely bunch of peer supporters, supervisors and experts by experience, and Louise Kirby is our lead within that, and she's done an amazing job. We've worked flexibly across the system, so across university hospitals, the 2 social care providers and the ICB, we've trained 7,846 staff in level 2 training, so that's the full day training. They've developed their own training charter and agreement about how they work together and how they respect each other's diversity and their own needs. And then they've trained over 1,000 people at level tier 1. So incredibly good results and fantastic for the team. So I'm going to hopefully share this. Hopefully you'll be able to hear the sound. If you can't, please let me know straight away. But this is a story about our Oliver McGowan trainer.
Hello everybody, I'm Louise Kirby, Autism and Assurance Lead in NHFT, but I've also taken a lead in the rollout of the Oliver McGowan training in learning disability and autism. We're really proud of our achievements and really hoping that it's making a difference for staff in their confidence in interacting with people who are autistic and people with a learning disability so that they can access our services as equitably as everybody else. I'm particularly delighted that Leo has agreed to come and talk to you today about his experience of being a co-trainer with a learning disability on the Oliver McGowan programme.
My name is Leo, I'm a stranger, I'm 26 years old and I live in Kettering. I'm diagnosed with autism and a learning disability.
What's your role?
I'm a tier 2 trainer for Oliver McGowan training.
Perfect. So why did you become an Oliver McGowan co-trainer?
I wanted to make a difference by helping improving the health and social care service for people with a learning disability or any other.
Perfect. And what do you enjoy about being an Oliver McGowan co-trainer?
I get to have some conversations with the health and social care staff and also give the best information I can to make the services better for people with a disability as possible.
Perfect. And what difference has being an Oliver McGowan co-trainer made for you?
It helped me boost up my confidence delivering the training to normally about 20, I'd say.
20 people, that's amazing.
Yeah, it's around 20.
That's awesome. And how do people feel when you give that training? Do you get good feedback?
Yeah, I get good feedback. They seem to be quite impressed with what I do. You know, I can now drive by myself.
Wow, that's amazing.
Yeah, because I passed back in July.
Oh, congratulations.
Yes, thank you.
You're welcome.
How did you find your driving instructor? Do you want to tell them?
Yeah, his wife works here. I can't remember her name, unfortunately, but...
Okay, but you had a good time when you did it?
I did, yeah.
Amazing. And what else are you excited for with that the Oliver McGowan training will help? So your confidence,
Yeah.
anything else? Like is there anything else you want to do? So you've passed your driving test. What's next for you?
Hopefully I can continue doing my training, maybe get another part-time job if I can.
That sounds brilliant.
Yeah, to save for the car.
Yeah, do save for the car.
Yeah, what car do you want?
Well, I'd be thinking also like a Volkswagen Polo or Golf, but they are quite a bit of money.
Why did you become an Oliver McGowan trainer?
It was advertised at the day centre I go to, and one of the staff that I get along with pretty well. Sadly, she's not here at the moment, but
That's why wonderful.
yeah.
And what was it like the first session? Were you nervous, or did you know what you wanted to do?
I was quite nervous because I normally don't really speak to large crowds, or at least I haven't done it for a very long time.
And is it delivered in person or online?
In person.
Wow! Oh, that's amazing. So there must be lots of different types of people who come to the training. Do you normally see doctors, or do you see administrative staff? What kind of people come to the training?
It's mainly doctors and nurses, isn't it? Yeah.
And that's important because
Yeah.
doctors and nurses will spend time with patients or service users who might have autism or learning disabilities. So what would you say to the doctors and nurses who are thinking about going to the Oliver McGowan training but aren't sure whether they should come?
Well, I think they should come and try to do the best they can, really.
Yeah. And what do you talk about when you're delivering the training?
Mainly it's learning disabilities like to deliver.
Yeah.
And you have a couple of slides that are just your own, I think.
Yeah.
You want to describe what you say, what's on those slides.
Yeah, it's got information about what I do. I live in Kettering. My hobbies are like my Lego. I like going to like amusement parks and fun fairs sometimes when I can. And also recently I watched the football, that local one mainly. But
Which local game did you watch?
it's Kettering.
Versus?
It was Cornwall. They didn't do too well in that game.
Oh, I'm a
No.
Rushden and Diamonds fan, I'm afraid.
Your other slide, does that talk about reasonable adjustments and what sort of things help you?
Yeah, I know one of them with the phone. Unfortunately, though, I only tend to answer the phone who's calling, unless it's like a 0800 number. I have to call it. But unfortunately, though, if I don't have it written down, I can't really answer it because I tend to mistake it for scammers because I have quite a few of them.
Me too. That's really important, actually.
Unfortunately, it's maybe hard to trust some. Unfortunately, I mean sometimes with my phone though, it does sometimes put up the actual person's name.
What do you think we should do to encourage people, to help people join the training? Like, is there a message you would give to our big people to say, let your staff sign up for the training, or, what would you ask of our executive team?
I'd say just do it and see how it goes.
Okay. I don't think I can say it any better than Leo. So that's the end of my presentation, but I'm happy to take any questions if anybody has any.
Great, thank you, Adam. I mean, that was incredibly informative. So if I go right back to the beginning of your presentation, Adam, firstly, thank you for taking us through that, but also coming back and closing the loop on and updating us on the previous presentation that we had from the Mental Health and Learning Disability and Autism Service, which was around the memory clinic, and some wonderful improvements there, and some really great efforts by the team. So please, on behalf of the board, convey our thanks to all the team for all the hard work they've done to bring about those improvements, and that great examples of partnership working with our colleagues in the voluntary community sector as well. So thank you for that. And then obviously having done the Oliver McGowan training myself, it really is incredibly insightful, really informative, and I agree with the points that Leo is making there about the importance of having people with lived experience as part of co-training, which is so wonderful because it does give you a different perspective, which I think is really helpful. So excellent for that. So let's bring in some colleagues. I can see a number of hands up for some questions and comments. Joe, let's bring you in first, our non-executive director.
Thank you very much, Adam. That was really, really good presentation. Thank you very much. And like Faisal, I'm a great advocate of the Oliver McGowan training. Louise and her team of co-presenters do a sterling job. The bit I'm going to focus on won't surprise anybody because I'm a bit of a crack record on this, is the whole prevention agenda. And the thing that I've just literally written all over my notebook here, Adam, is the mean death age slide that you talked about and some of those figures where 42% of the premature deaths were avoidable. I just find it absolutely alarming that in this day and age, given all we understand about this group of patients and care and people with care needs, we still have such distressing figures. Is there anything that the teams need that would help to approach these issues more directly? Because obviously, cardiovascular respiratory cancers, they're all the things that are easy to diagnose if people present in time. And how do we, as a healthcare system in Northamptonshire, better prepare all of the partners who may have contact with this group to be more mindful of the issues that they face?
Yeah, it's a really good question, and like you, it's a shocking statistic regionally, that mean age. I think we can't underestimate the importance of the annual health checks and our commitment with our local GPs to make sure we attain a really high percentage of getting people through those annual health checks on a regular basis, and really ensuring that the bit that our teams do within NHFT is reach those kind of those service users that struggle to get to the GP or perhaps don't engage. The piece we pick up is that ability to go out with that annual health check perhaps and see them at home or get them into that space and make sure that happens, and drive that forward. I think the other part is that being inextricably linked through the MHLDA collaborative, then the outputs of the leader review sit squarely within that transformation that LDA pillar, and then it's for the system to own in Northamptonshire how we tackle those. And I guess it's an unfortunate thing that we have to focus so strongly through a leader review on this group, but it tells us exactly where we need to focus, and it gives us that ability to target those key areas. So I think at the minute it's for the system to pull together around that pillar meeting and around that MHLDA collaborative to think about how we tackle it. But in the primary, NHFT and GPs continue to focus really heavily on getting those annual physical health checks through.
Thank you. And Faisal, if I might just follow up. So where would oversight be of the implementation of the review if it is that the MHLDA? Where do they report into? Is it an ICB oversight?
Yeah, the report sits with the ICB. So it's published on the ICB's website, and then the management of the outputs will go through the pillar.
Okay, brilliant. Thanks, Adam.
Yeah, thanks for that, Joe. I'll bring in Itai because he can just kind of touch on the physical health and learning disability. But I agree with Joe. I think Adam. I think we as a society really have to do better for this cohort. I think in terms of the national challenges for this cohort, in terms of addressing health inequalities, this has been known for many years. And whilst there are better kind of physical health checks and getting to this cohort and providing support, we still don't seem nationally as a whole society doing enough for this community. And as you say, Adam, the Learning from Death report just highlights that. So thank you for sharing all that information. Isa, let me just bring you in before I bring in Angela, just on the physical health checks and anything else you might want to just touch on.
I just wanted to add that Dr. Tom Houseman, who is the clinical lead for the LDA collaborative, who was initially seconded to NHFT, is now employed within the MHLDA collaborative. He's a GP by background, with a special interest in learning disabilities, and I think his clinical leadership in terms of the leader review, etc., has been invaluable. So he continues to feed back to us on a monthly basis in MDDMT. So we've got that connection with primary care, which I think is key in terms of early diagnosis. And there's a lot of work to be done, but I think the setup that we currently have, puts us in a very good place to be able to solve some of these issues.
Yeah, thank you, Tommy. That's really reassuring to hear, and given that we've got good systems in place to help support within the Northamptonshire system. So thank you. Angela, let's bring you in next.
Thanks, Faisal. And just a few comments really, Adam. I wanted to thank you personally, because I think your compassionate leadership and your commitment to co-production is really compelling, and I think that's really important to say and acknowledge, and I think that comes across in many ways, but particularly through the learning disability, the work in particular. I think it's really important, and it's building on what Itai said actually in terms of the collaborative, because those national issues, those national figures, the challenges that exist are helped enormously by having the collaborative in place that we've got, because it does give a partnership approach, and it can only be improved through a partnership approach. So I think the fact that the collaborative exists is really important to us in Northamptonshire. And I think, you're leading one of the pillars, which is really key to this work. And I'm really encouraged and see personally the commitment from partners, because people do come, they do commit to it. And what Adam's described in terms of people wanting to work and improve together is not a typical picture in every part of the country. And I think, again, that comes back to the approach in the collaborative generally, but also to Adam's work as well. So just wanted to reinforce that. Thanks, Adam.
Thank you, Angela. I was going to say that's really very helpful. Adam, did you want to come in back there before I bring other colleagues?
Yeah, I think I completely agree, Angela, and it's why I included the space framework within this, because I think one of those other to go back on Joe's point, one of those other points about the preventative is if we don't have the spaces that the 110 people that had autism only could go into, so if they won't attend our A&Es and our and won't go in an ambulance because of the way because of how bright the lights are and how it's delivered to them and the type of communication they have, then it's a really wonderful space that we can work in as a collaborative to make sure that anybody with that neurodevelopmental needs within the county knows that the offer they get will be considerate of those needs, and then they're much more likely to engage. So it's an essential piece of work for me, I think.
Right. Thank you, Adam. Melanie, let's bring you in next. Melanie, you're on mute.
Well, one of us had to be the first one, hey? I might be the only one by the end of the meeting. Firstly, I just want to second Angela's comments about yourself, Adam, because I've been lucky enough to be on a service visit with you, and that passion, compassion and commitment is evidenced in spades. I've also been very lucky to do a service visit to the Willows, and also last week just attended an MDT meeting with the Intensive Support Unit, and can absolutely kind of give my own sort of evidence and assurance around the incredible approach of the teams, the benefit and value for the patients of having those services wrapped around them, and just an incredibly impressive set of services that we have to support. I wanted to ask, particularly Adam, two quick questions maybe. One about if you could just maybe expand a bit about how we tackle the health inequalities bit, particularly as mental health, we know learning disabilities, and autism are viewed and treated sometimes differently in different ethnic and cultural perspectives. So I wondered if you could just talk a little bit about the work that you're doing to kind of engage proactively with those, and also recognizing the difficulty with autism maybe in some of the diagnoses. just the sort of the ability to work with people who maybe haven't received a formal diagnosis, but recognizing that they see themselves as autistic, or at least are displaying the characters of neurodiversity.
Yeah, thank you. Yes, so I think the key to the engagement with the and you referenced the kind of our global majority communities. I think the key to that piece of work for me is the neighbourhoods work that we need to progress in the coming years as part of the long-term plan, and actually as through the transformation pillar, we're going to lead on that work. I'm just developing a workshop that will come on board as the neighbourhood plan develops with the ICB, bringing that on board in September to sit with the 9 neighbourhood localities, bringing together all of their voluntary faith and cultural sectors into that one room alongside NHFT and our GP colleagues, to make those links across those areas physically and start to talk about what mental health, learning disabilities and autism pathways look like across that range of services. Because and in a way the diagnostic centre showed this, there's so much work that could be done pre-statutory services if we make the links, build the confidence, get the training right. There are so many organisations out there that want to help and want to engage in that proactive space, particularly in LDA, but they need to know that we're alongside them and that we're with them if they start to struggle. And I think that's where the benefits of that neighbourhood way of working will come for me. And because I sit in that pillar, LDA sits exactly with me in that space as well. So it won't be neighbourhoods for mental health, it will be neighbourhoods for all of this. So that would be my view around that. Your second question has escaped me because the first one, your second question was...
Sorry, it was about people who might identify as neurodivergent,
yes,
or autistic, but haven't yet received a diagnosis, and how do we handle that?
Yeah, I think I think that's it's. I often talk to people about this needs-based way of working. If any of you have ever been to a supermarket when they have a period of time when they make it adjusted for someone with neurodevelopmental needs, I can assure you most of you will feel that's the better time to be in that space. It's darker, it's quieter, there's not so many people. And I think we need to get in that world of that needs-based way of working where it isn't all about diagnosis, it's about how someone will best receive the care that we need to deliver and how we engage with them in that space. And I think the other thing is we know that unfortunately over the years, as people have transitioned perhaps from children's services through into adult services, we've probably missed the opportunity to diagnose in this space. And certainly we're finding people with diagnosis perhaps of personality disorder or complex emotional needs. We are now overlaying a view that says actually maybe we've missed something around their neurodevelopmental needs. So I think it's important that the space framework and our Oliver McGowan training point us in that direction the whole time, make us think about it the whole time. But for me, this is needs-based care. This is looking at the individual, sitting with the individual and saying, how do you want it delivered, regardless of what your diagnosis is, and how can I best make that happen?
Thank you, Adam.
Thanks, Adam. I mean, that's really helpful. And I think one of the things as colleagues have been asking questions and making comments, and your responses to some of those really brings to life for me how many elements of our Thrive strategy that we've touched on today, and that's really really quite key, particularly around being responsive, thinking and keeping the focus on the service user, the patient, the family, being think about healthier communities, which I think is just great, and also about involving everybody, as you were quite clearly pointing out. So thank you for that. Dave, let's bring you in next.
Thanks, Faisal, and thanks, Adam, and obviously really glad to see you getting the feedback. It's people with fire in their bellies that make real differences to these communities and pathways, a bit like Oliver McGowan's mother in terms of getting that training stood up nationally. I suppose just two things. I think you might have answered it with Melanie's question. One was about, obviously Leo's kind of exposition on the training was powerful, and many thanks to him. And the trust is doing really well on that, actually. We're above kind of 85%, and as a board, we're at 100% in terms of compliance. So just to reassure Leo that we're doing what he was asked we should do. But I wonder what next, like when we consistently achieve that within the training, and we obviously see the benefits for our patients, but is there another step beyond that to try and continue the journey of improvement for these services and for people with a learning disability and or indeed autism? And it might be that you've described that in neighbourhoods. And I was particularly taken with Leo's kind of ambition about getting a car and getting another part-time job. And I wondered, yeah, is there more we could be doing to support those opportunities for people? I'm particularly thinking about some of the recent developments locally with some Workbridge and other kind of facilities, whether there's a space that we can maneuver ourselves to try and kind of continue to provide that really great kind of life opportunity for people with diagnoses of learning disability and or indeed autism.
Yeah, I think it's a really good point, Dave. And I think what I've asked kind of assistant directors within the MHLDA pathway to think about is kind of where the autism and the neurodevelopmental kind of bit sits for me, and it isn't purely LDA. And I think that's the important starter for this for me, that autism, that neurodevelopmental sits across everything we deliver. It's erroneous for me that it sits there. It's across everything, and I need all of those teams to be thinking about that first in their engagements about, you know, how do I work with someone? Am I looking at and it speaks to how we did engage with our culturally diverse community as well. It's a similar way of working, isn't it? That we talk to people about how they want their care to be delivered. So I think, you know, we absolutely need to focus on what our training needs in a much more broader sense are across all of our services, to make sure that we never end up in a position where someone coming into one of our services saying they've got autism and us saying, well, that's that service over there, because it fails to meet all of the interdependencies that you can still have mental health issues, you can still have physical health issues, you can still, and so we need to get away from that. And I think that is really encouraging. And then, you know, that if you take neurodevelopmental difficulties across a much broader spectrum of the way that we work, then we're talking about the use of, you know, that individual placement support work that we do through getting people back into work or helping them find work through the work that we do through that team, and with our partnership with Accommodation Concern, where they support people in finding work and benefits and housing. And, you know, we've got so many good ways of linking in with the wider system that I think, but for me, it's just about neurodevelopmental concerns being a constant normal narrative across all services. That for me is key.
Thanks, Adam. And Natasha, if I bring you in finally.
Yeah, and I think Dave and I were probably thinking along similar lines, because actually it's picked up threads as well of, I think, what Angela was talking about in terms of partners and collaboration there. And I don't know, Angela, whether or not the question should come to you, but also I think around neighbourhoods, because I was really so first of all, I say, in terms of coming back to us on the memory clinic, thank you for bringing us the update. It's really important to hear the thread and the progress and that continuous improvement mindset, and how you're bringing that to new areas of our population. So first of all, I want to really thank you for that, because it's been such a fantastic improvement that team have been through, that you're bringing it to more people is superb. But the question I had was really about the Homes for Life, and I think also to Dave's point around like employment, and how do we, I suppose my question is, how well are our partners supporting residents of Northamptonshire to have the Homes for Life and the integrated employment opportunities that this population need, and how well are we meeting that need to provide that locally within to where they live?
Yeah, yes. It's a really difficult area. The commitment is there. It's absolute through the MHLDA collaborative. It is, and the LDA pillar is chaired by Sam Fitzgerald from Adult Social Care, which is a real bonus for us in the county. I think certainly having that transforming care team and almost forensically understanding the needs of each individual and what they need to come back out into the community is definitely challenging us as a system. It's challenging the norm of what we have in the way of providers within the system and what our estates footprint looks like and what our housing footprint and those opportunities. And I think it's kind of wonderful in that thankfully it's a relatively small cohort of people that are in long-term hospital placements. It gives us that opportunity to really nuance care around them, and I think certainly the conversations I sit in, we are all aware that we have to do something different in the county. We can't do what we've always been doing, because that's why these people are still in hospital. That's why they haven't got those homes for life. So for me, and Angela might talk about the feeling at the board, but certainly for me, the commitment feels absolute through the pillar structure.
Thanks, Alan. That's really helpful. Angela, let's bring you in.
Yeah, we'll just echo what Adam said about the commitment. I think, you know, it's pretty compelling, the commitment in Northamptonshire, actually, in terms of the partners around the table. And that doesn't mean it solves problems all the time or it's got the answers, but commitment is so significantly important in that first step. And we get regular attendance, really solid attendance from local authority partners and the wide, you know, partnership sector, which is again very, very, very encouraging. And we've had debates about housing and employment and the importance of those as really significant. And I think, again, spending time, we have time as a collaborative, also some away sessions where we've done some deep dives on different things, and that's where you're trying to solve more wicked problems together in terms of things that, you know, are challenging all partners. So I'm very encouraged. I think, Natasha, that doesn't mean that we've got, you know, everything sorted. We haven't. We'll still have significant housing issues and employment issues, but that commitment is compelling. And I think that the more that we can demonstrate the linkages and the partnership working and the importance of how we improve outcomes together, I think that becomes so motivational for people, and also delivers value, because people then see by bringing resources together, we can actually make a difference collectively. So I think the collaborative is pretty significant, and I think there's more it can do, but I would want everybody to be very clear. The commitment from partners, I think, is very impressive.
Thank you, Angela. That's very helpful to hear and understand the context about the commitment, but also the work that's going on in the collaboratives, which I think is very helpful and very heartening to hear as well. Adam, look, really, as you can see, very engaged, really informative presentation. You know, as a number of colleagues have said, your compassion and your kind of understanding and care for the areas that you work in really shines through, even through the world of digital on-screen meetings. So huge thanks to you, and please take back to the team, and especially huge thanks to our lived experience co-trainers, and thanks from all of us on the board. So very much appreciate it. So we'll move on to some of our more formal part of our business, and as always, please, for purposes of the board meeting, I will always take it that all the papers have been read. Please, for report authors, just to highlight any key points they want to draw the board's attention to, so we can keep focused on those key strategic issues and questions that we want to pick up. I was so keen to hear the presentation. I was out of my starting block so quickly, Adam, that I forgot there was paper C in the packs, which is our forward plan for our board meetings, which is a standing item, just to give everybody an indication of what's on our forward plan and what is being planned, and that's constantly reviewed and looked at. So just for your information, everyone. And then we're into our risk section, and the first bit is kind of oral update, and this is around the system-wide winter planning, and that's I believe again with you, Adam.
You'll have to bear with me on that. That wasn't a paper that I was ready with.
Okay,
It's not a paper. It's not a paper.
No, it was just a verbal update on where we're at with the thinking about our system-wide winter planning. It's something that normally Anne would have picked up. But Dave, do you want to come in?
Thanks, Faisal. Yeah, I can pick that up in my managing director's report, actually, just as a bit of the environmental context.
Fine.
Yeah.
Okay, great. Thanks. Sorry about that, Adam. So we've got to normally as Anne picks it up, but I've got on my annotated agenda. It just said that it was you. So Dave will pick it up in the paper, managing directors and the environmental scan. So we'll move into our strategy section, and you'll notice that this time around in our NHFT board meeting, we've not got the chief executive's report because we've got the group board later. So Andrew will be taking the report there. So just if you're wondering why that's not on the agenda, that's clearly for those purposes. So we'll move on to our environmental analysis first, kind of key highlights, anything with Andrew or any of the executive directors that you want to pick up. Andrew, let's start with you.
Thanks, Faisal. So as you say, only a couple of things because of the nature of the group board opportunity, but important to just share and acknowledge that we do have a new Secretary of State, and obviously the Right Honourable James Murray has now joined us in the NHS, and that's obviously an important change that we should note. And then importantly, to share our good news in terms of our Advanced Foundation Trust opportunity that we've been progressing through NHFT as Wave 1 candidate, and really pleased to say that we have now received that formal notification from NHS England that we have achieved that position and status, and that's really, really important for several reasons. One, because it is an acknowledgement of a position of strong foundations, which we clearly have been producing and progressing over several years, and that's important for our communities. But secondly, I think it's also a recognition of the support that we had from partners. And I would want to take the opportunity to thank everybody internally and externally that helped support that application and that submission, because we were very well supported by our partners. And I think that's really, really encouraging, and I think sets us in good stead to use this opportunity for the benefit of our population. So just want to say thank you to everybody, and to formally record that position, which is very important. And I believe that that is going forward as of the 1st of June. Thank you.
Thank you, Angela. Yes, very much need to endorse that, and a huge thanks to everybody involved with all of that process, but not least our stakeholders and partners who've supported us through that process and puts us in a very good place, continue to be in a very good place to spring forward to do more for our population in Northamptonshire. So thank you. Anything else from any of the other exec directors, anything that isn't covered? Sarah, let's bring you in.
Thank you. Yeah, just to note that it was in the news yesterday that resident doctors will be taking further strike action 15th to the 19th of June. That's the 16th one. Thank you.
Yeah, thank you, Sarah. Keep us apprised on this. Dave?
Thanks, Faisal. Just a couple of things. One is just ongoing. This probably links with the earlier item on winter planning and pressures, etc. There is pressure in the system locally currently, significant demand for urgent emergency care pathways, and we've got significant pressures indeed in our own mental health beds, which I know Adam will concur on. But we're working coherently on that. EMAS are probably standing up an incident in relation to some of their pressures. So just to flag that for the board is, timely that we're here today, but just to make you aware of that. And then just in terms of health and wellbeing boards, I haven't included a section in my managing director's report, but just to update one thing which I think is positive in terms of the obesity pathway in the north, particularly. They are looking at revamping the approach used for obesity and the approach in the county for obesity, adopting a public health educational approach. So rather than just a focus on being active or you doing sports, etc., all the things that we know make a difference, actually going beyond that into what really makes a difference for people, what works for them, and working with a strengths-based approach. And I just really welcome that, because we've tried some of the other work, as we know, in our own pathways. We've tried different public health approaches to managing the prevalence of obesity, and we're not seeing the results. So I welcome the opportunity to try something different, and welcome the Health and Wellbeing Board taking a bit of a leadership role in that as well.
Excellent. Thank you. Thank you for that update, Dave. Very much a helpful angle to be taking. And as you say, the Health and Wellbeing Board taking the lead on that is welcomed as well. Linda, let's bring you in.
Thank you, Faisal. I just wanted to mention that there was an article that was released in the media yesterday by the Nursing and Midwifery Council, NMC, who are the professional regulators for nurses and midwives in the UK, so all the 4 nations, around checks where registrants made declarations. These could be previous convictions or health disability related issues, which resulted in an urgent review being taken by the Nursing and Midwifery Council. So just to mention that they've identified 421 registrants that they have written to request further information, and the emphasis on the regulator is that this is an error that has happened with them, not the registrants. So I just wanted to provide some assurance that within NHFT, we carry out our regular checks. So we will go through our screening of our staff, and annually registrants will make a declaration. So just to mention that this is a very small number of nursing and midwifery colleagues that have been identified, but we recognize that once it's in the media, there will be those concerns around these colleagues. So any further updates we will have in due course, we'll bring those through, but it is really a very small number. They're requesting information, so we'll only know when this process is completed. Thank you.
Thanks, Linda. I think the board will take a high level of assurance from that approach, but also the local checks and balances that we have in place and the screening processes. So we'll wait to hear further information as and when that becomes available. So thank you for that update. I'm not seeing anything else from any other colleagues, so thank you very much for that. And in the chat, Richard has reminded me that under the risk section, if you're wondering why we're not looking at a risk report, that's also because we've got our board assurance framework and risk report being captured in our group board later today. So that's just there if you're wondering why that report isn't there as well. So thank you, Richard, for reminding me in the chat. And then if we move on to paper D in your packs, which is the chair's report, which is with me. And again, I'll assume the report's been read, but if I just pick out a few highlights, just the importance of the role our governors play, and a few of the colleagues, Joan, Natasha and myself, had the benefit of being at an in-person induction session. I can't remember, was it last week, Joe? I think it was last week. It seems like a lot's happened in that period. It really insightful, very informative, but also to be in the room with our governors, getting around the table, having some table discussions and some of the invaluable work that they do and their lived experience that they bring, including existing governors, but also the new governors who've joined us. And given that we had recent elections, so we welcomed Ronnie Hill, patient and carer governor, Prince Caesar and Peter Williscroft as public governors for Kettering and Corby, and Charity Nicosia as public governor for Wellingborough and East Northants. So it's really great to see the work of our governors in person. It was a great opportunity for me, certainly in my since I joined NHFT as interim chair, to meet some of our governors in person, which was wonderful, really, to meet everybody there. Again, a few weeks ago during International Nursing Week, a number of us attended the nursing conference that was held in Leicester, but it was jointly held between LPT and NHFT. And again, I know, Julie, you were there, and Linda opened the event on behalf of the organisation from the board. It was a really inspirational day, huge amount of networking. Dave, I know you were there to open the session up as well. It was just wonderful to hear the insightful and informative presentations, but also the tabletop discussions. And one of the things that I took away from the amount of energy in that room being shared and the networking that was going on between colleagues, so hugely important. So felt it was very important to share that. Not to embarrass Angela, but the Annual Health Service Journal Top 50 Chief Executives was published. Angela, you again in the top 5, and the last few years you've been number 1 and number 2. And as I said the other day in the LPC board meeting, no pressure. You've got to maintain that now. You know, we're going to be watching that very carefully. So well done to you. Huge congratulations. And also for all the team that support you to ensure the work that we're doing for our population in Northamptonshire. And just a final thing I just wanted to touch on very briefly. We meet regularly as Leicestershire, Northamptonshire and Rutland chairs and chief executives across the University Hospitals Leicester and University Hospitals of Northamptonshire. With our ICB colleagues, and Angela and I attended that session. Just the reason I bring that up today is just the amount of commitment and collaborative working that we're doing as system partners, which also includes East Midlands Ambulance Service there. So it's a really good to see that clear, close partnership working is taking place, with talking about system working, with trying to implement how we can address through system working and implement better solutions and better health outcomes for our community. So I just wanted to share that with you. And there'll be in the appendix a whole range of visits and meetings that non-executive director colleagues have been on. Is there anything anybody wants to particularly draw their board's attention to? Julia.
Thanks, Faisal. I couldn't let this go without just another quick mention about International Nurses Day event, because 2 things struck me afterwards. One was, as you said, the huge bonus that people connecting with each other across both trusts, and the table I sat on, the connections that were made, and the people from each organisation that were going to then, you know, contact each other afterwards for the benefit of patients and service users was absolutely phenomenal. But I think the other thing that really struck me was how in really challenging times, it's a real indication of the values of an organisation and the people that we say to people, we value you, come to this event. You know, there are nurses from wards, from community services, and some of them said to me on the day, you know, I shouldn't have been released today, they're so busy back at base, but actually what they got from that day, the sort of the rest, restore, learning, sharing to take back, was so invaluable. It was incredible. So it's just a shout out to Linda and her team for organising such a fantastic event, but actually a reminder to us that this time out for people is so important. And I think as a board, I really sort of listened to that as a board member, and really applaud all our services for releasing people to go. This is really important. So thank you for that.
Yeah, thank you, Julia. I mean, I think the learning together part of that was really key. I mean, it was just amazing. And I think certainly as chair, meeting our staff and hearing their personal stories, but also the opportunity just to connect with staff, I felt was an incredibly important opportunity. But with also, as you say, Julia, across our group, sharing information, some of the quality improvement research projects that were shared, which is fantastic. So well done to everybody who was involved with organising that. Tasha, let's bring you in next.
Yes, because I wanted to share a couple of things. One around the Governor induction day. Just really wanted to reiterate your comments, Faisal, around how lovely it was to meet face to face. And I think for all of the non-execs who were there, we got a huge amount out in terms of meeting our governors, and I think vice versa, that collaboration and shared working. So yeah, big thank you to Tracy and Richard and the team for bringing us together in person. I think it was a great way to build those connections and strengthen, I suppose, that accountability to our population. And secondly, I just wanted to again just really celebrate the clinical audit team who had their clinical audit celebration day on Friday, which Louise and the team were very kindly allowed me to join. Just the focus on the range of things that are being done through clinical audit, the thousands of staff who are involved in clinical audit was really really humbling, actually, for me to see actually how significant a programme of work it is that team deliver alongside all of their clinical colleagues, but also the candour with which they shared their findings and the responsiveness of the teams when they needed to really act very quickly to address what they found with a really positive learning mindset. And that really impressed me and came through really strongly in all of the presentations across mental health and physical health. So a really fantastic day, and just looking forward to next year. And just really wanted to shout out, I think, the really fantastic work that clinical audit team is doing.
Lovely. Thank you for that, Tasha. That was really good to hear, and huge thanks to the clinical audit team for all the work they're doing then. Duncan, let's bring you in finally.
Thank you, Faisal. First of all, I entirely support and endorse what you and Natasha have said about that meeting with governors induction. Really, really a great opportunity for those of us who attended to find out more about them, their work, and how they contribute and support our organisation. Turning to service visits, I wanted just to share with the board the service visits I've had, a couple of them recently, to our colleagues in the speech and language therapy service, and in particular highlight to the board the really, really great work our therapists are doing on therapy outcome measures, TOMS. It was really impressive to see the way that they translate meaningful engagement with our service users into conversations, diagnosis, and therapy going forward for those individuals, recording them in the system and making sure that this is a meaningful exchange of information and a meaningful opportunity to drive the individual's health and well-being forward. It's something in the NHS, Faisal, I don't think we do anything like well enough. And I think we should celebrate the fact that our speech and language therapists really are doing some outstanding work in this area. Thank you for that.
Thank you, Duncan. And I would completely endorse that there's some excellent innovation taking place, including the speech and language therapists supporting some of our inpatient settings where they're working with how to communicate with people with dementia and also other nonverbal skills and how to approach individuals. So yeah, huge recognition to the work they're doing. So thank you for sharing that from your service visit, Duncan. So with that said, we've received the chair's report for noting for information and seeking any further clarification. So thank you to everyone for that. And then we'll move on to paper E in your packs, and this is the Managing Director report. Dave, and this is with you.
Thank you, Faisal. So just a few bits to pull out. One, just linking from Angela's comment about the Advanced Foundation Trust. Really great to see recognition of Chat Health in the Integrated Response Hub being awarded the HSJ Digital Award in the category of Improving Mental Health through Digital at the ceremony in May. You recall that being part of the AFT process does require us to be able to demonstrate the 3 shifts kind of in clear terms. So having an award that recognises that, I think, is just helpful in the context, and well done to the teams involved in that. Also linked to that theme of analog to digital, we've also seen NHFT now ranked in the top 10% nationally for trust for our type in terms of our digital maturity. That gives us the highest score in the Midlands. Again, just a really great basis for further work in part of the 3 shifts. So just to call those ones out. We've also launched our Thrive Awards, which bring together a new framework for linked to our strategy. And we had a good session with our trust on our trust talk, promoting those, and they're obviously our new reward and recognition program, and they also dovetail now with a difference makers scheme, which is replacing our Compassion Champions, which has been a very successful program over a number of years. So that Difference Makers will be rolling out across the organisation, and that maps across to our work within group similarly. Our Serenity SARC sexual assault referral centre, which Faisal you've talked about before in terms of attending service visits there. They've been accredited one of the first adult and paediatric SARCs, awarded the UCAS accreditation, and it really places Serenity at the forefront of assault referral services nationally, and just well done to the team. They're hugely passionate about what they do there, and it's great to see that recognised nationally too. I'll pick up the NOF in the integrated organisation report, but just to reflect here, that we remain in segment 2, and we've been assessed as having no statistically significant change in performance since our previous rating, which again is positive. And similarly, linked to that positive frame, the North Northamptonshire Council have been shortlisted for the Most Improved Council at the LGC Awards. That's great, great for them because they're passionate about what they do, but also great because they're partners and we work closely with them across a number of services. So it's brilliant to see that improvement because that'll benefit our patients and it benefits staff and it benefits culture. So it's a multi-pronged success story. And I'll just call out some service visits, Faisal, partially just to ensure we remain grounded from ward to board in terms of the feedback. So there's a bit more granularity in these than perhaps I would previously have put, but that's just to kind of demonstrate some of the grit that is coming now through the service visits and leading to improvements in terms of the work that we're doing with services. And I won't go through them in detail, but you can see the spectrum of concerns raised from staff. We're obviously able to then demonstrate their advocacy for patients, which is the CAP-AV discussion about just card payments rather than cash. And I thought that was really positive to see that because it just shows we're really being person-centered. We're thinking about patients all the time and thinking about their experience. So I just thought that was lovely and something for us to work on. I won't go any further. Some elements I'll pick up in the integrated organisational report, but generally a positive start to the next year of work in the trust. Thanks, Faisal.
Thank you, Dave. And as always, a very comprehensive report to read. So thank you to you and the team for all the work in pulling that together. Any questions or comments? Joe, let's bring you in first.
Thank you very much. Thanks, Dave. Some really exciting things coming through the Dragon's Den route, still, those 4 items. Just in terms of closing the assurance loop, where do the outputs from these trials get reported into? Because I'm conscious that we've obviously been running the Dragon's Den process for a while now, and it would be good just to formally record somewhere at board the success stories attached to these and the opportunities for group learning. Thank you.
Yeah, good idea. I'll bring Itai in. Thanks, Joe.
Yeah, so our performance based on our Dragon's Den is recorded in the Research and Innovation Governance Group, which meets bi-monthly. We also produce a report to the Quality and Safety Committee as part of the AAA, which includes not just our ongoing research projects, but outputs from our innovation. But it would be good to just do a focus on just Dragon's Den and possibly bring it to board just to see the story so far. Some huge success stories in terms of, quality improvement and also generating efficiencies both within NHFT and within the system. So it will be good to highlight those.
Yeah, thanks, Itai. I think that'd be a really good idea. Thank you.
Yes, thanks, Itai. Thank you, Joe. Julia.
Thanks, Itai. Thanks, Faisal. Yes, Itai, I agree. I think I'm just coming in on that point. Sometimes in the committees, we do see a vast amount of information and it filters through from various other groups into the committee. And you can't always distill the detail down to the board enough. And I think this is a really important area and it plays into also our research and innovation BAF risk. So I think anything that gives us a real oversight and a sort of a summary to celebrate the improvements, because it's all directly impacts patients, families, carers, etc. So I think that's a really good idea to bring a summary to board level. Thanks.
Yeah, thanks, Julian. Richard very kindly and helpfully has reminded me that we've got in one of our board workshops where we're going to be focusing on research and innovation. So as we'll be coming together as 2 boards in common, we'll pick that theme up there as well. So thank you for that reminder, Richard. Before we move on, Dave, I wanted to just pull out one thing from your report as well, from the Managing Director's report, which was the Freedom to Speak Up reporting app, which I just think that's another excellent innovation about reaching out to our staff to be able to speak up. So there's a whole range of measures that we've got in place, a whole range of mechanisms for people to report and speak up about anything in our organisation. But having this app just sounds like another great innovation. And am I right in assuming that that's actually gone live, Dave?
Yes, and linked to the form as well on the staff room, all providing further anonymous routes for people to raise concerns through to us.
Yeah, excellent. And that, I mean, again, that just made me think about how that links into the 3 shifts in the 10-year plan, but also our own Thrive strategy around being technological and digital. So excellent. So thank you very much for that. And then I'm not seeing any more questions or comments for our Managing Director and Deputy Chief Exec. So we're just asked to consider this report and receive it for information and seeking clarification, which we've done. Thank you very much. We're a little bit ahead of time for our break. I mean, if it's okay with everybody, I'll proceed if you're happy, and we move into our integrated performance section and then take our break a little after this section if we're made up our time, if that's okay. And then we've got the Alert, Advise and Assure report from performance, and this is with Joe, as you chaired that meeting.
I did indeed, yes. Yes, I did. Thank you, Faisal. Again, take the report as read. I'll just pull out a few themes because I think they tie in with things we've already talked about, but also things coming up on the agenda. This was effectively an end-of-year performance committee looking at significant progress across the year. So I'll pull some of those headlines together. The first thing to just give confidence to the board around was the assurance deep dive subject, which was around wait list, and it's something we've talked a lot about in board meetings. And the performance committee looked at, again, in detail, particularly the 7 service areas which are particularly pressured. And we gained a lot of assurance around the work that's been going on this year, particularly around data cleansing, so that we're working off a very solid base for information for those 7 services. And they're now in a position where they're looking forward to lots of innovation and improvement, particularly during this coming year. So whilst the story is positive so far, I think we're going to see some really good progress made across those particular 7 critical areas. In terms of other strands for assurance, we did pick up again on the risk strand, and it's something we talked through, and I guess, you know, the link through to the Audit and Risk Committee will ensure that this is done in a balanced way, is just how we tie the corporate risks together and ensure that we have a consistent view across the structures given the group arrangements as they're bedding in. In terms of the integrated organisation report, again, lots and lots of detail. And in the context of a closed down year, I think it's important to just contextualise what a significant year of change 25-26 was, particularly impacting us in terms of the changes to the commissioning structure as the cluster arrangements with the ICB took shape. And as we know, the blueprint had lots of consequences upon their working structures, and also just the need to reposition themselves. And you know, I think it's helping us prepare for the opportunities that will come from the AFT news in terms of looking at opportunities for us to take some lead in terms of work programs, particularly some of the community service and neighbourhood health work. Obviously, you know, what we want to do is ensure that we're having a very patient-focused outlook on these sorts of things. And again, a lot of the stuff that we received in the Integrated Assurance Report, which Dave will take us through shortly, was around understanding how the coordination and commissioning activity is giving a stable platform for us delivering services now. So the Performance Committee were really, really pleased to gain assurance about our performance outturns. There are still things that we need to improve, but generally really positive directions. Also to note was the really, really positive outturn in terms of financial delivering slightly ahead of plan, with improved access to services and actually tackling some of the persistent issues around waiting lists and bank usage and agency usage, and still delivering the financial targets. Workforce, again, we'll perhaps come on to this a little bit more in detail. We still have some adverse performance against targets, particularly given some of the historic legacies we're picking up from the new prisons we've taken on. But there's lots and lots of work going on, and I'm sure Tim will give us a bit more detail with Sarah on that later on. In terms of the NOF, Dave's already touched upon it, so again I won't go into too much detail on that. The report sets out the details. We still are in segment 2, which is good. We do have some performance issues, but again the committee are keeping a firm grip on the areas that we need to focus on. One really good news story, which it would just be good to put in front of board, is the continued improvements that are going through in certain areas where we've had particular problems in the past. So MSK is one to flag, and I think we need to recognise that they've put so much work into shifting that service forward. On the other side of the coin, we still have some pressures in community paediatrics. I know there's lots and lots of work going on in the background to stabilise that service and actually build a sustainable plan for transformation in the long term. But again, just to offer board assurance that we have it on a radar at Performance Committee, and we'll continue to keep tight monitoring on that. Let me just skip forward a little bit, because I say a lot of this is going to be covered in Dave's report that follows. In terms of the NOF, the NHS oversight framework, one of the things that the committee considered doing, and we've sort of buried it under the assurance bit, so I just wanted to put again a flag on it. There are going to be some new NOF indicators emerging for 26-27, and we've sort of hinted at an advise status on some of those figures, because obviously we're already operating in 26-27, and there may be some gaps between the actual stuff and the things that are going to come through to us to monitor and record. So we just need to make sure that we're not getting gaps between actual performance activity and forecasts. So we're waiting for that to come through. Just skipping ahead then towards the group value programme section of the report. Again, positive progress being made across all strands. The group strategy Thrive is providing the new framework for us to work within, and certainly colleagues within HFT are embracing it fully, and it's helping support frontline staff to deliver that consistent, safe and compassionate care that we all know that the trust is renowned for. An area which has taken a lot of focus over recent months is the contract transfer for the new prisons. The transfer is now complete, and since taking on the first wave of prisons back last summer, and then through to the final takeover of North Sea Camp, there has been additional contract costs incurred in all of those settings, but under the transition arrangements with NHSE, the trust is indemnified against additional costs falling directly to us. So again, just to assure the board that that is continuing to be monitored through Performance Committee. And just a final element under the assure section of the report, just to reflect back, we had a really good session around digital in terms of a digital update, but also looking at the new digital plan. And the digital plan is going to be a key enabler for us to continue to progress with the developments. We're looking at delivering safe and efficient services to all of our patients. And the final section, just because it's always nice to end on a positive, celebrating outstanding. It is a continuation of the digital theme. We just want to record to board the significant work that went into the onboarding of all the prisons. The digital team have done an absolutely incredible job in ensuring that all of the staff there, as they join NHFT, have had access to all of the services they need through the digital channels, and it's a considerable achievement to have achieved all that. So that's the summary from Performance Committee, Faisal. Thank you.
Thanks, Joe. We received that report from you as you're chairing that session. Before I take sorry, Judy, you want to come in with a question or a comment?
Thanks, Faisal, and thank you, Joe, not only for chairing the committee, but also for delivering the AAA. I just wanted to add a couple of comments, if I may, very briefly, and that's really to congratulate finance team. Janine is here representing the team today for delivering our break-even for last financial year. I'm very aware that we're almost 2 months into the next financial year, but this is our first opportunity to say this in public board. And also in relation to the ongoing financial reports for our current financial year and also for the medium term, there will be some changes in the report to reflect the value programme going forward, so that there's assurance around the right level of information. Paul and I and the team have already agreed. Thank you.
Thanks, Judith, and for that update as well. And we'll receive the report for information and noting, and we'll then move into integrated performance, and that's with integrated. Sorry, I've lost my thread there for a second. Integrated organisational report, and that's with you, Dave.
Thank you, Faisal, and thanks, Joe. So obviously a lot of material. And the executive summary gives a kind of an overview, so I'll just give some broad headlines. As colleagues have said, a good start to month one and a good close down indeed from last year, and echo those congratulations to all colleagues, and particularly for the finance plan. But we still have some high-risk areas in relation to ongoing pressures in weights, which we're making progress on. So the waiting list performance has improved overall. 92.9% of patients seen within 18 weeks, and it's reduced by 5% in April to 34,000, with a further reduction in those waiting over 18 weeks. So I think reassuring that we are making progress. The plan is manifesting in results, which we're seeing in the numbers, and hopefully we'll be able to sustain that over a period of time. So a good start, as I say, but continued pressure. Our workforce indicators are mixed broadly, but they are improving. Sickness improved for the third consecutive month to 6%. We had a good session with our staff side colleagues on our sickness plan earlier this month, where we'll have kind of some outputs of that, which we'll bring forward into the People Committee with Tim's leadership. But we are making progress, it would appear in the data. Our mandatory training and appraisals are both at or above target, and that's a strong position maintained over many months. Patient experience broadly remains strong overall, with 93.4% of service users recommending NHFT, which is above the 90% standard. And as colleagues have said, our finance plan is ahead of plan at month one, with a deficit of 1.18 against a planned 1.4 deficit, with bank spend slightly better than our plan, which is positive to see. Equally, just in the IOR, the transformation delivery is strengthening, so 68% of projects are on track, which is an improvement from Q3. And as others have said, there is really strong alignment now to digital and community-based transformation ambitions. So that pulls out two of the major shifts, the analog to digital and inpatients to community. So thematically, we are seeing that reflected in our transformation programme, so we can be confident as a board that we are tipping into the national policy in that sense, aligned to the Thrive work. I've talked about the oversight framework in the Managing Director's report. We remain in segment 2, with improvement in access to care, mental health length of stay, crisis response and staff sickness metrics. We are expecting in the new framework, when the detail is published, that the UEC measure, which is one we've performed pretty strongly on over the period of the NOF being in existence, that is being removed. But we'll bring an update through to Performance Committee in terms of our forward scan on those measures when we've got it. So just in terms of board oversight, we have some long waits remaining that Joe has talked about in some of our children's and our autism and Asperger's services, and in our gender identity services, which we're working through as part of Performance Committee and indeed Quality and Safety Committee oversight. On community paediatrics, we'll cover this in private board, but obviously there is reference in the executive summary. There is, work underway, due diligence in terms of the NGH provision of services in the locality, which we'll pick up, as I say, in the private board discussion, because that does present a performance challenge to us. Our vacancy rate has increased to 10.2%, and that does reflect wider workforce pressures. And as part of our value programme going into 26-27, we have had to take a very robust position on vacancies in the organisation, as we did last year. But of course, safety comes first, and there's a break clause provision for vacancies as required if they're required to be released into the organisation. But as part of our overall risk management approach, both in terms of quality and safety, but also finances. Patient safety incidents are above the upper control limit, and as Joe said, that does reflect some of the onboarding of new services, Notts and Lincolnshire secured services particularly. But most harm incidents were low severity, but the volume remains high. And again, we take some confidence from a high volume in the sense of it's a good reporting culture, but we need to be able to differentiate what are new issues that are coming through in the organisation as part of onboarding new services. And that differentiation will be important in terms of the NOF position, because it may have an impact on our NOF, but equally we need to be able to demonstrate why, and that's the important bit. We have done work in the Patient Experience Committee around adult mental health experiences being below the 85.5% standard, and there's a programme of work coming through that Wayne Lawrence is leading on improving that, so we're gripping that at subcommittee level. And then just in terms of looking ahead, as I say, we've started the year in a strong position overall, really great progress in access and workforce performance and transformation delivery, but we continue to have a good board focus and committee focus on long waits, as Joe described with that detailed review that we had in Performance Committee this month. Similarly, keeping an eye on vacancies and patient safety incident levels in the context of onboarding new services will be an important focus for us going forward. Thank you, Faisal.
Thank you, Dave. Again, a very comprehensive report, and the appendix that's captured in the pack is really well laid out, very easy to follow, certainly since I've joined the organisation. I welcome the clarity by which the information is provided. So thank you to you and all the team for the work that goes on behind that. Given the tremendous amount of pressure and challenges the NHS has been under, there's some excellent examples of some really great green shoots emerging, Dave. So thank you for that. And whilst we recognise that there are still challenges, that the teams are working very hard behind the scenes to ensure that the trajectories and the work on plan is there to help adjust that as we move forward. So thank you. Please convey that. Thanks back to everybody. Dave, any questions or comments for Dave? Julia.
Thanks, Faisal. Thanks, Dave. Really comprehensive overview. I just wanted to add in an additional piece of assurance around waiting lists, just to remind people that perhaps don't know that actually through the Quality and Safety Committee, we do have a look at harm reviews for services with waiting lists. We also have a process to look at waiting well initiatives, and we do receive some reporting on that. So that sort of complements the deep dive at Performance Committee. And also just to say that you'll see in the next paper, which is from the Quality Committee, Itai, as Chief Medical Officer, advised us that there'll be a quality summit for the community paediatric team, and that's a really great process where they bring together all the information about a team that can be reviewed holistically and then look at what can improve. And that formal reporting also comes back through Quality and Safety, and I'll bring that through in the next Q&S report when we get that further detail. So it's just to add that extra bit of assurance to that. Thank you.
Thanks, Julie. That's a really helpful bit of information, and I'll actually look forward to seeing that come through the highlight report in future board. So thank you for that. Any other questions or comments for Dave? No? Okay. Thank you, Dave, for that report. So we're asked to receive the report for information, noting and seeking any clarifications and addressing any risks identified, which we've done. So thank you for that, Dave. Quality section, and we move into item 12, and the paper H in your pack is the alert, advise and assure from the Quality and Safety Committee, and this is with you, Juliet.
Thank you, Faisal. So this is the Quality and Safety Committee from the 30th of April. There were no areas to alert, but I've just given you a couple of lines on actions following the last alerts to the last board, just so that you've got the information there. Under the advise section, we noted a couple of quality summits, and we've just mentioned the community paediatric one, which I think ITI is able to give us a quick update at the end if we want that. But also there'd been literally just been one on Bay Ward following a CQC Mental Health Act monitoring visit, and we'll get to the results of that and all the information fed through to the next committee. We've referred to the People Committee an issue around safeguarding level 3 compliance, really important for our groups of staff that require that training, because that compliance level had been dropping, and we felt it was something that should be looked at in the round. And so Tim and I have had a conversation, and that's going to be taken up by the People Committee. Excuse me. Under the Assure section, our assurance focus was around the 11 CQC Mental Health Act monitoring visits that had taken place over the last year. It's a really good source of assurance for us. We really welcome external views on governance of our mental health inpatient units. There were over 40 recommendations. They were addressed by over 100 actions, and they were mostly complete, which is fantastic. And we were fully assured by the work around all of those. And it brought out a conversation and a wider focus for perhaps a future assurance session around how we cascade learning across the organisation, the mechanisms of that, and also the impact. So actually, we're going to take that forward to a future session, which is really good. A couple of areas that we've asked for a bit more assurance on. One was from the Quality, Safety and Assurance group around caseload management within our mental health teams. Again, we're going to get some further assurance at the next meeting. And the other was from the regulatory update, just to get an update on our call bell system, ways that people call for help across our estate. There's been a huge amount of work over the last couple of years to make sure everybody has access to being able to call for assistance when needed. There are a couple of areas we were not sure about, so we've just asked for an overall summary just to come back for full, complete assurance. A couple of really good reports. One was the Q4 service visit report. As always, this very good maturing report gives us some themes from service visits that Dave has already gone through in his managing director reports. But we also received the first annual report on the service visit, and it's really given us a chance to reflect on the value of these visits, not only for us to see and hear what's going on, but also staff feedback to us, the really positive response for us being out there and listening, and the actions actually are taken away. They're tracked by the exec team, and then things do change where they can. And so we just suggested that some more examples could be given in that of where we've made changes. And I know Dave's put that already into his managing director report. So I think for next year, there'll be a few more examples come forward. We had our regular update on the patient carer race equalities framework, and it's a really important area that the board needs focus on. And just a few things we asked for a bit more information on going forward. We also had our first annual summary of our prevention of future death reports that Richard Smith brought us. Again, very strong assurance, and that a few themes were beginning to emerge, that work's been taken forward, and that has oversight through our Learning from Deaths Group 2. 5 policies were endorsed, they're listed there for you. We also had the privilege of looking at the draft quality account, which I know is a bit later on the agenda, so I won't go into that, apart from to say that we put down formal thanks to everybody involved in that, and we'll comment on that a bit later on the agenda. And then lastly, the celebrating outstanding. We too had so many examples. It's very difficult to trim down and pick out what to share. Dave's already mentioned the Sexual Assault Referral Centre, phenomenal, being the first in the country to gain accreditation for adults and paediatrics. I wanted to pull out our library and knowledge services because we've just joined the Midlands Evidence Repository, and actually that raises our profile as a centre for research, really helps around researching existing evidence for innovations, etc. So that's really good. And we had numerous examples through our service visits that I've mentioned there. And then the last one, really important work by our trust clinicians, helping to develop restrictive practice guidance, and that's a national piece of work. So just wanted to give some airtime to some of those this time, but phenomenal amount of work going on. So that's our summary. If anybody's got any questions, or I don't know if you wanted a very brief summary from Itai, Faisal, I'll hand back to you. Thanks.
Thanks, Julia. Yeah, let's bring you, Itai, because it's been mentioned about the community at PEDS session. So if you just give us a quick snapshot.
Yeah. So we'll be providing a detailed report to the Quality and Safety Committee. We had the Quality Summit yesterday, and we picked up on a number of themes that had led to our waiting times being prolonged. First of all, the service is carrying out a broad range of functions, which, the commissioning amount doesn't actually match the workforce required to be able to carry out all the functions. Other workforce pressures include carrying 2 consultant vacancies and the community pediatricians being very difficult to recruit to. Some of the mitigations which are in place are the recruitment of a clinical fellow who's now working at consultant level and will soon be able to sort of work much more independently and contribute to the reduction of the waiting lists. There are opportunities for other roles such as advanced clinical practitioners to pick up some of the stuff that don't necessarily need a consultant, thereby freeing up capacity to power through some of the waiting lists. There are opportunities with us becoming lead provider, having a larger workforce from the West, which is currently delivered by NGH, and that will allow us to have a trust-wide, a county-wide named doctor for safeguarding rota, which will enable us to work much more efficiently than we are currently. So we've taken some actions from that Quality Summit. We'll feed that up to the Quality and Safety Committee, and we will have a recap of the Quality Summit to look at how we are sort of performing against the projected trajectory of reducing those waiting times and improving our waiting well.
Right. Thanks, Itai. That will be helpful to take that report back to Quality and Safety, and we'll pick that up through subsequent AAA highlight reports. So thank you very much for that. Linda, let's bring you in.
Thanks, Faisal. I just wanted to come in on the point around our safeguarding level 3 compliance for children safeguarding and adults. Just to mention that it was discussed in Quality and Safety Committee around, as we're taking on more services that will affect compliance. So committee wanted assurance around what was being done with regards to that, because the training model is face-to-face, and given that some of the areas are out of county, then that would impact our compliance. So that was one of the areas that we were looking at, and committee was then asking Quality and Safety Assurance Group to provide a breakdown of the information so that there was assurance. So that will come through to the next Quality and Safety Committee. The other issue that has then come up is we moved to all ages training, and that was in recognition of the models so that they covered both areas for our clinicians. That was the level 3 children's training and the level 3 adults training. So in essence, we should have the same compliance figure being reported for safeguarding level 3 children, safeguarding level 3 adults, but it appears that we're still reporting separately. So we are looking at what has happened with our reporting, because for the children's training compliance, which is above our trust 85%, sitting at 88.68%. And then we have the anomaly query around adults, which is sitting at 83%. So we just want to understand that, and we are being supported by our workforce analytics team around that. So we will be able to send that information through to our quality and safety assurance group. I just want to mention it because I know we've got the chairs for the joint people and culture committee to just mention that we're doing the work, and I wanted the point clarified. Otherwise you won't have the full information, but we will present it. It is being actioned and looked at. I just wanted to mention that it's actually two parts of that, just providing the committees that assurance and that we continue to monitor it. Thank you.
Thanks, Linda. That's very helpful, and no doubt it'll be tracked through quality safety. But thank you for that update and giving us the information and some wider context. So that's appreciated. Thank you. So not seeing any more questions for Julia and the AAA highlight report from Quality and Safety Committee, which we receive for information and noting and for assurance, which we've done. So thank you to the Quality and Safety Committee and to Julia. And then we move on to paper I in your packs, which is the Patient Safety and Learning Assurance Report for March and April. And that's with you, Linda.
Thank you very much, Faisal. It is a long report, so I'll take it as read, but just tease out a few highlights for the board. So within this report, what we have done is reported on our activity for March and April 2026. We've used the statistical process control tool, which we hope you'll find useful because that assists us in understanding whether or not we are deviating from what we would expect as reasonable practice. So we review that, and when we look at reasonable, we're looking at the contacts of the particular service, the population. So we look at a number of metrics to come to what would class as reasonable. So it's not just one aspect of what are the numbers. There's a lot of other information that we triangulate through that. And then we've got the comparison there just so that you can see the information when we are reporting on the top 5 patient safety themes that we report. So where we've reported on increased reporting around pressure ulcers, we've provided some assurance around that together with the ongoing work from the pressure ulcers group. So there is a group that reviews all pressure ulcers that is outside of our review of significant events. That's outside of the quality safety assurance group. So there's a specific group that looks into that aspect particularly, and that's to ensure that we are preventing pressure ulcers, and where they do occur or we receive patients with them, that we are managing this really well and effectively. Within the report, I've provided the update on our clinical investigations, which is a position that we continue to monitor so that we are completing investigations within a timely manner, but with the focus on learning, because that's absolutely key for us within the organization. I've also ensured that within the report, we have attached the learning from deaths report. So that's the Q4 report we discussed earlier around the learning from deaths for patients with a learning disability. Leader Adam mentioned that earlier. We had that through the presentation. And just to reiterate what Adam had said around a review that's going to take place, which will result in a pause of the group meeting to review, but actually the work will still continue around that, so we'll be able to report on those deaths in due course. So I just wanted to highlight that as well. Within our learning from deaths report, you will see some examples of learning, and that's key for me to highlight to board because that is what the group is established for, so that we can learn from these deaths, and where we can improve our practice, certainly we would look to improve that. I'm happy to take any comments or questions with regards to this report, Chair.
Thank you, Linda. And again, must commend you on a very comprehensive report. There's a lot of information to draw out from that. So thank you for that. Julie, let's bring you in first.
Thank you, Faisal. Thanks, Linda. Really, really comprehensive report. And actually, you've preempted a couple of things I was just going to comment on, to say that actually it's really important that the board see the learning from deaths information, and it sort of goes alongside the preventing future deaths report that Richard brought through Q&S as well. It's good to see that there was one case that was going to be referred to LEADER, whoever the new provider is, that we'd reviewed in NHFT at our Rose Forum. So we look forward to seeing that come through, quality and safety. But what I really, really like is the examples of learning, because they actually identify actions that have been taken. And that's another thing we're going to look at when we have a focus on how we share learning. Sometimes learning is identified as we should do this and we should do that. This is actual actions that have been taken to improve practice. And I really like that. And that, as you say, that's really important we focus on that. And the good practice examples too. So a really balanced report, and take a lot of assurance from the whole report. Thank you.
Thanks, Julia. I would concur that we as a board take a huge amount of assurance of that the work that's taking place. So thank you, Linda. Any other questions or comments for Linda? Tasha.
Yeah, thanks. So just a very tiny one, Linda. I think there's a typo on page 92 at the bottom. Your dates are repeated in 2 sentences. So I think your comparison is just a little bit hard to understand. So that just might need noting in the minutes in terms of what the correction is there. I wanted to I also wanted to, on page 98, it was really lovely to see the support coming from LPT as well around the patient safety instance. And I just wanted to pull that out. For me, that was a really nice demonstration of group and the strength of group to support one another. And then the only thing I was really reflecting on the pressure ulcers data when I was reading this report this time, and I thought, was reflecting, it would be really interesting to understand how many of those patients are progressing from grade 1s, 2s, 3s, 4 whilst in our care, and actually how proactive. What are the measures, I suppose, what's the because I know there's a lot of work going on in terms of the pressure ulcers group, your new champion, etc., around how we're really trying to be very proactive at those early phases of pressure ulcer management, to make sure that we intercept and prevent progression. And I suppose I was thinking about that with the prevention agenda as well in the back of my mind as well. So just would be really lovely to maybe kind of see some of that data at some point in quality and safety around how we're looking at that progression whilst in our care.
Thanks, Tasha. And I'll leave that with Linda to pick up and I know there's a huge amount of work that's been going on on the pressure ulcer work, and it's been reviewed, and I know there's been workshops in the past, so it's timely to bring some that further information back through quality and safety. I'm not seeing any more questions or comments for Linda, so in that case we're asked to receive and note the report for assurance, which we do, and then we move on to paper J in the packs, which is the monitoring workforce and safeguards report. And again, that's with you, Linda.
Thank you very much, Faisal. Again, another detailed report, which I will take as read. Just a few highlights for board. So within this report, we've provided information on our monthly fill rates. So that's our staffing levels and activity levels within our inpatient wards. So there's appendix with that. And having taken on board previous feedback, we've also then provided the information around the bed occupancy. And you will see that they're aligned together with any explanations where if the bed occupancy is lower, but the activity levels, i.e. fill rates, are higher, that's attributable to service, to the patient needs. So where there's increased observations for patients, increased support required for those patients. So we've provided that information within the report. Also within the report, we continue to highlight our vacancies. And I just wanted to mention that with regards to highlighting our vacancies, we have included medical vacancies together with a breakdown. So what's being done now by the Matron for Safer Staffing will be to provide that breakdown for nursing and AHP. We just want to provide assurance that these are not all band 5 entry-level posts. There will be different posts, and you'll find with some of the posts they do require some specialism knowledge around them. So that's not all entry-level band 5 posts. So we'll be able to provide that assurance right through into our reports that will go to the Joint People and Culture Committee. So we just want committee to be assured that these are not all vacancies attributable to our value program, but there will be vacancies attributable to various things, including requiring the right skill, right person to then fill those roles. So we'll be able to do that as we have done with the medical vacancies. We've also provided some information which is key within this report around the multidisciplinary team consideration. So when we use our tools with regards to safer staffing tools within the inpatient areas and the community areas, it focuses on nursing. But what we've done is we've provided some assurance around multidisciplinary support into those teams that has resulted in matrons confirming that the areas are safe in April and certainly haven't been reported through in March. I've also provided an update with regards to our establishment reviews where the data is being collected, and this information will then be triangulated, presented within a report at the end of this month. I just wanted to also mention that within the report itself, there's been a lot of information that's been reported, including the work that goes into triangulating any incidents that occur to look at whether or not staffing has impacted on those. That continues on a day-to-day basis as incidents are reported through DATIC. So a lot of work goes into reviewing those incidents together with looking at where there's higher level of reporting of incidents. Again, we will have the Safer Staffing Matron link in with those teams to get further understanding so that that is reviewed. I'm happy to take any comments or questions, Chair, with regards to this report.
Thank you, Linda. And again, thank you for a very clear report, and thank you for drawing out some of those key highlights from the report. Let's take some questions and comments first before I come back in. Angela, let's start with you.
Yeah, thanks, Buzz. It was just really a comment. I thought it was encouraging anytime I want to comment further in terms of recruitment activity for medics. There's some improvements there in that April figure, and I think that was really encouraging. We were talking, weren't we, yesterday in terms of some of that approach. So again, I just wanted to note that because again, seeing the adverts, seeing the difficulties, you described community peds, but seeing some improvements and something coming through was really encouraging. But again, I know it's something close to your heart and you're working on it continuously.
Yeah. And I suppose just to add, I think Dave will remember, that at the beginning of this week, we had an interview for a community pediatrician who is going to be joining us shortly. So that will cover one of those vacancies. I think we've had a steady recruitment. Our GMC fellowship scheme has also helped us to grow our own consultants because they come in as clinical fellows, and 5 of them are acting consultants now. So we've got a really good trajectory in terms of, agency avoidance, quality improvement through having more substantive staff. So it's really helping in terms of the value program and improved clinical quality.
Thanks, Itai. That's very helpful. Duncan, let's bring you in next.
Thank you, Chair. Board colleagues will recall that the Audit and Risk Committee received towards the middle of last year an update from TIA, our internal auditors, on the budgeting of medical staff. I had that in the front of my mind as I read in particular the table on vacancies and making sure that we got that progress coming back into the Audit and Risk Committee. I wanted to just report for the board that I think we're due to have you and Paul come back and brief us on the updates. You've kindly given us a written update. given me a written update as time progressed. But to have a full discussion of that in September, Faisal, and then we'll report back to the board where we are with that. Thank you.
Thanks, Duncan, and we'll look forward to receiving that through the AAA highlight report from the Audit and Risk Committee. Thank you. Melanie, let's bring you in.
Thank you. Remember to unmute myself this time. Yeah, so much good stuff in the report and great to see a lot of the reductions in temporary staff usage. I had a particular question, which in fairness, I think is a referral to the People Committee around the role of mental health first aiders in supporting some of the sickness absence we have, for which stress, anxiety and other psychiatric illnesses is referenced in this report. And I just thought it would be interesting to understand, because I think we have a couple of hundred mental health first aiders across the trust. It's a key role, and I think it would just be really interesting maybe to understand a little bit more about how that role is and can support the sickness absence activity and the sort of stress and anxiety of our workforce. So I guess, Tim, probably a referral to you, and maybe it's collected within the overall sickness absence deep dive that's going on within the Joint People Committee.
Thanks, Melanie. Sorry, Melanie, did you want to come back in there? Oh, right. Thanks. I just wanted to double check, Duncan, your comments about the Audit and Risk Committee, was that in relation to this report? Because I just missed it for a moment.
Yes, it was. It's in relation to the budgeting and the level of vacancies on the medical staff. It's one of the outstanding issues that we were asked to take a look at during last year. And I think, just to recognise it, I and Paul, I think, have been making great progress on this, but we'll be receiving that formal update and reporting it, as you said, through the AAA report coming back after September.
Okay. Adam.
Just wanted to quickly come back on Melanie's point about staff wellbeing. We've certainly through the Trust Organisational Management Group, last month we agreed to cement the investment that we have into 14 Arches, which is the psychological support provision that we have within the Trust, to ensure that that's still available to as many staff as possible. We've also been doing some targeted work around restorative supervision in our wards, and Arabella Kurtz has, she updated me this week about some work that we've been doing with, particularly with Marina staff, and you'll be aware we closed Marina a good while back, and one of the interventions we did was around the psychological well-being of the staff because of the nature of the work that they do, and they've been very receptive to the idea of restorative supervision within their workforce, and we're looking at bringing that through in a number of wards. So there's active engagement in those spaces, but always work to be done. I agree, it's a real key area of delivery for us.
Yeah, thank you, Adam. Thank you for that update. That's helpful. Thank you. I'm not seeing any more questions or comments, so thank you for the report, Linda, and we can receive the report for information, and which we do. And I think there was a bit of the report that said the Trust Board that this report is recommended as advisor to note the actions described in the areas where alerts have been raised, which we've done. So thank you for drawing our attention to those, Linda. And then we move on to paper K, which is the quality accounts, and that's still with you, Linda.
Thank you, Faisal. I'm really pleased to present this draft version of our quality account, a reflection of the work that has taken place throughout the year 2025 to 2026. The report has been structured so that there's a flow to the information, and this is based on feedback that we've taken through from board quality and safety. So thank you, and I hope the structure of our report reflects us taking on board the feedback. So we've structured the first part to talk about quality, including any challenges that we've faced. The second part is our performance. If you remember last year, we were talking around outcomes and what this means for patients. So we've put that in under performance. And then the last part of the report looks at our next steps and our future. Overall, with regards to pulling together this work, we recognize that it has been busy. We acknowledge, as we've been talking around things like sickness absence, recruitment, but actually this reflects the work that we've done, the work that has gone into us achieving our priorities, and the work that we've also carried out across the system. So just also want to mention that we did present this draft report to Quality and Safety Committee. We are now at the stage of looking at getting stakeholder feedback ahead of us being able to publish the report on the set deadline, which is the 30th of June. The ask from board today is that you note the work that has gone on to us producing this draft report. It's also to ask that you delegate authority to Quality and Safety Committee, who are meeting on the 25th of June, so that we are able to publish the report on our website on the 30th of June. And also just to ask board to note all the work that has gone in from colleagues, not just those in nursing and quality, but in the various other groups across the organization, care delivery pathways, our colleagues in comms, as well as colleagues in strategy and partnerships, who have all supported us to bring together this report. I'm happy to take any comments or questions. And before I do that, I'll ask if Julia has any other comments she wants to raise, because it has come through to Quality and Safety Committee. Thank you, Chair.
Thank you. Is that okay, Faisal, if I just join in? Yeah, thanks, Linda. We also acknowledge, I think you've summed up very eloquently the number of contributors to this, and we also, QNS, recognise that hugely. And I think the word I wrote down to share is how proud I feel, and I think the committee felt, and I'm sure as a board we feel, the amount of work to improve quality and safety across the organisation continuously. You know, times are quite difficult challenge sometimes, and we've just got to take a moment to step back and reflect, because this is all about the work of our staff day in, day out, and it's just absolutely phenomenal. I really like the inclusion of the case studies. That brings it to life for me, and that's really welcome this time. The focus on health inequalities, on our digital innovation, just to bring out a couple, it's just phenomenal. And I think it's a great showcase, but it's also very honest about where we haven't perhaps achieved what we've needed to in some of our priorities and the work that we're doing to, you know, carry on. So I look forward to the stakeholder comments, as we always do. But actually, just take a moment, I think, as a board to say thank you to everybody for a fantastic year, I think, for quality and safety across the organisation. So thanks, Linda.
Yeah, thanks for that, Julia. And thank you. I would, on behalf of the board, would completely endorse your comments there. So thank you. Judith, let's bring you in next.
Thanks, Faisal. Thanks, Linda, for presenting the quality report. Totally support and echo everything that Julia has already said in relation to the amount of work that's gone into it. And this was recognised at the at QNS. It was a really fantastic report to return to QNS, rejoin QNS, to see the summary of all the work that we have done. The one supportive challenge that was discussed, and I think reflecting on it since, I definitely think it would be an improvement, is that the report is very qualitative, and some people, you know, really struggle to read that amount of words. Whether going forward, any thought could be given to making it more visual, more quantitative by way of bar graphs or charts, etc., just to break up the report, the reading, and make the ease of to bring an ease of reading to the report. But apart from that, an absolutely stonking report. Well done to Linda and the team. Thank you.
Yeah, thank you for that, Judith. And I think we had a very similar conversation, Angela, you'll recall, at LPT a couple of 2 or 3 years ago, where with the quality accounts where that same point was made. And I think that evolution has brought us to a really good place. But certainly, Linda, I think with regards to the report, it was really clear to read, and as Julie's already articulated very well, there was lots of really good stuff in there, but also the candor with which, where there are some still pressures, how they've been recognised. But I shall leave that with you and the comms team to take away to see how we can make it more visually appealing. And it's always difficult when there is so much to put into these reports and to capture and to share all the key areas that is required for the quality accounts. So I'm not seeing any more questions or comments. So with that in mind, we're asked as a board to note the draft report, which we've done, and to delegate authority to the Quality and Safety Committee to receive the final version, to sign it off on behalf of the organisation, to make sure that we meet the deadline before the end of the June, which we are happy to do so. So thank you to you, Linda. And please convey thanks to everybody who'd been involved in putting this together, because I know you've named a few people, but on behalf of the board, please do take back our thanks to everybody involved. I know what a huge piece of work it is. So thank you very much. That then moves us on to our governance and assurance section, and paper L, which is in your packs. This is the Alert Advisor and Assure highlight report. And Duncan, this is with you as chair of that committee.
Thank you, Chair. So first of all, let me highlight the fact that we met towards the end of April in the understanding that we were just successfully negotiating the end of a really strong financial year on numerous levels. And the committee was held in that context, but also recognising that our colleagues in the finance team have still quite a lot of work to do to go and get the annual accounts process over the line, and our auditors satisfied with everything that's gone on. So let me just, if I may, pull out a few items from our meeting and the AAA report for board members. The first is to, I use the word alert, but it is alerting of a few minor changes to the terms of reference of the committee itself. These reflect essentially some of the changing roles, how we're bringing the anti-crime service more front and centre into the work, and some of the name changes that we've had, along with the increased role that the managing director plays in his attendance at the committee. If I then may move to the advise elements of the report, the assure elements of the report. We had nothing to advise, I'm pleased to say. Under the assure, let me start off with, we had our second of our discussions with the chairs of other tier 1 committees. First discussion we'd had has been with Julia at a previous meeting, and so we were happy to invite Judith to come and discuss the work of the performance committee. The discussion really acknowledged the good year we've had, but then started to look on what we had learnt from the year in terms of the assurance to be gained from the committee's activities. I guess the first thing to note is the enormous agenda that the performance committee has to manage in terms of the sheer scale and number of the board assurance risks that were there. We had some debate and discussion about the depth of analysis that is presented to the committee. If I may just pull this out, the year had a number of changes from the original plan, not least of all the Trust's decision to accept the secured services into our contracts, and the degree to which the committee had received reports under the people heading, under the ops heading, and under the finance heading. We were trying to figure out what was the right level that we should do that with. And and in particular, how we should consider changing plans when we have a major change like we did last year with the secure service contracts coming in. So there was a lot of learning there discussed. We also noted the great triangulation. It really was a great example of triangulation between the Green Plan, the Estates Plan, and the Value Programme. The discussion as a whole really brought far more depth of understanding and assurance to us in our understanding of the performance of the Trust as looked at through Performance Committee. And as such, really, in recognition of the work of the committee and Judith's explanation of that to us at Audit and Risk, that came in as really the highlight of the committee under the celebrating of outstanding. So thank you, Judith, for your contributions to that. Under other matters of assurance, the work with the annual audit plans, both internal audit and external audit, were noted as proceeding well. We had a couple of recommendations from the internal auditors, which on face of it looked like we might have been just dropping back a bit, but on closer examination, the committee noted that these were really just housekeeping issues and there was nothing to be concerned about there. And we are expecting that to return to the previous high levels of achievement. Our colleagues from the Counter Fraud Service gave us the update on where they're expecting us to get, in particular with counter fraud, and I'm pleased to report that that was all looking in very good order with a green rating. Our external auditors also provided us with a really good update on what's happening in the wider health service and how audit and risk committees and more particular boards and their subcommittees should be looking at the questions of the free shifts. And we've highlighted that with the Director of Corporate Governance as a potential area for taking into wider training through potentially a workshop. If I were to close, we also noted the SFIs, which we were due to revisit, and I was happy to recommend to the board the SFIs as per the version we received, but to note that we may well have to come back to our standing financial instructions and scheme of delegation if the Trust's ambitions for becoming more involved as an integrated health organisation contract holder were to be realised. This is an area we're going to have to revisit. And then finally, under this heading, Joe highlighted earlier an issue that we have been discussing at Audit and Risk Committee about how the corporate risks are given transparency to board members and the Tier 1 committees. We had a meeting with my counterpart at LPT, and we are going through a process kindly facilitated by our Director of Corporate Governance and the one from LPT, Richard and Kate, as to see how we can align our practices so that board members from both committees essentially have a more transparent view of corporate risks and do so in a way which is familiar no matter which board meeting or group meeting they're attending. I'll leave it at that, Faisal, and happily take any questions.
Thanks, Duncan. Any questions or comments for Duncan? No? Okay, thank you. So we received the report for information and noting in the AAA report, which we've done. Thank you very much, Duncan. And then we move on to paper M in your packs, which is the draft annual governance statement. And this is with our Director of Corporate Governance, and that's with you, Richard.
Thanks very much, Faisal. Yes, paper in the pack is showing the draft annual governance statement, or AGS, which segues nicely actually from Duncan's remarks on the annual report and annual accounts processes. This forms a part of it. We're in a good position overall this year, although clearly awaiting the final considerations of the auditors before we can finalise the AGS and indeed the annual report and accounts. It's here really to advise the board on where we've got to in preparing the annual governance statement, and also to share it in public in advance of the final version of the annual report and accounts being received in public in September. So I won't go through the detail of the report, as it's hopefully self-explanatory from the paper, but we'll happily take any comments or questions from board members, in particular if there are any areas of the AGS that we could or should strengthen in advance of the final version. Thank you.
Thanks, Richard. And again, I found the statement to be very clear to follow through and read, Richard. So thank you for that. Joe, let's bring you in first.
Thanks ever so much, Richard. I'm a bit nerdy when it comes to AGS documents, but one of the things that just made me reflect when I read through this was, although we don't have it articulated as a significant corporate risk in our structures in our BAF, there is something about a medium-term risk profile around prevention and health equality. If we don't get on the front foot for that, we're just going to end up with more and more demand down the line. And I'm not seeking to revisit the BAF in any sense. I just think that maybe some of the commentary that sits around the document could perhaps point towards these sort of medium-term risks, which are broader societal risks, but nevertheless they are partly our responsibility alongside other agents within the Northamptonshire system.
Shall I come back in?
Yeah, come back, Richard. Thank you.
Yeah, really good points, Joe. And I think, as you say, the distinction perhaps is the AGS is sort of looking back at the previous year, and your comments very much are reflecting on where we're heading in the future. So maybe they're best reflected in, as you say, these sort of wraparound materials rather than in the AGS itself. And perhaps it's something that I can pick up with David in terms of his lead on strategy, that we can then spend some time reflecting on that and then ensuring it's appropriately articulated in all our planning and strategy documents going forward.
I accept in principle, but I just put a bit of challenge in here. I accept it is a retrospective document, but the fact that it's not, when I would say, are we on the front foot with it? And if we're not, should we not be flagging that it's maybe something that the broader system needs to be alive to? Because it's, this is a public facing document, and I do think that conversation with our partners. I mean, it was interesting talking with governors at the induction session. I was fortunate to share the opportunity to speak to some of our council governors, the West Northampton, North Northampton representatives, and and it's a challenge that we all face. But unless we publicly recognise it somewhere, I think it's going to be difficult to gain that collective momentum, because then, if you extrapolate this forward, there is something about that contract with our communities about self-care and early diagnosis, which does take that responsibility from providers to the communities themselves. And I just feel a bit uncomfortable that it's silent on that, but I bow to your judgment. Thank you.
Yeah, thanks, Joe. I think in terms of the prevention bit that you refer to, Joe, that I'll bring in Angela in a moment, but there is a huge amount of work going on through colleagues in public health in terms of recognition and being on the front foot. Again, I think that's something that we could ask colleagues to look through the health and wellbeing boards in our council organisations, but also thinking about that, the joint needs assessment that is presented could be another way to capture that. And I think the point that you're making is about how do we track that across and bring it into our recognition into an annual governance statement. Richard,
sorry, Faisal,
Yeah.
I'll just respond there. But critically, I'm saying it's a risk. That's the point I'm trying to get across, and obviously not doing it very well. But I say I'll bow to Richard's judgment. It's just it's something that we need to be alive to, I think.
So certainly I would ask you to continue that conversation with Richard outside of the meeting to kind of make sure that we've captured it as well, Joe. Angela, just bring you in for a moment.
Yeah, so just a couple of comments really. I mean, I think, Joe, as Richard said, there's clearly, as you describe, a need to consider that prevention as system-wide. And I think we've had those discussions in various forums, haven't we? And I think, as we say, going forward, that will be very pertinent. I think what's important, though, is to understand the AGS in terms of its frame and what we're doing. And I think the sense of these are our board risks, and there is, as Richard said, a retrospective view of that in relation to this framework that's in this statement. That doesn't mean we don't have opportunity to have a look at those risks going forward. And I think, as you say, it's important to keep those live. And the board has that opportunity, as we do, in a dynamic way, to look at risks and to understand how we capture it. But this is what we've clearly got as a board currently that we are now commenting on as part of that annual government statement. Thank you.
Right, can I just finish off, Faisal? Thank you, Angela. Yeah, I acknowledge completely that it's a reflection of the current board structures. I was offering an alternative, which is just using some of the commentary that sits around the document to capture that. But I think I'll take you offline and speak with Richard.
Yeah.
But thank you for that. Thank you.
Yeah, thanks, Joe. Not seeing anything else, Richard. So you're asking us to receive the draft report and note the progress. So thank you, which we've done, Richard. Thank you very much. And then we move on to paper N in the packs, which is the annual effectiveness review of board and committees. And that's still with you, Richard.
Thank you, Faisal. Yes, so this is in some respects like a heads of terms, really. It's seeking the board's input on the specific questions and frame of this year's annual effectiveness review of both the board and the committees before we then get cracking and launch it. So you'll see in the report the background on why we do the survey, which is hopefully fairly self-explanatory, and the proposal for both boards and committees in terms of the specific questions we wish to pose. I hopefully have captured some of the nuance in discussions that we've had at committee level and at board level in terms of areas where we feel there might be further opportunity to improve in future years. You'll note an outlined timetable in there for the surveys and overall exercise as well. So it's really here for any tweaks or comments from board members and ultimately approval to proceed. And we'll then revert back later in the year with the outcomes. Thank you.
Thank you, Richard. Again, just looking at the report and the proposed approach, eminently sensible and seems to have covered all the bases very well, Richard. Let's bring in colleagues for comments and questions. I'll bring in first Julia.
Thanks, Faisal. Thanks, Richard. Comprehensive report. Sorry for an obvious question, but as we literally on the 1st of April had a shuffle round of NEDs attending different committees, presumably you'd ask us for our retrospective view on last year. So, for example, I was on performance committee the whole year last year, but just on one audit committee now. So just to double check, it is for last year and the attendance at those committees. Is that right?
That's right, Julia. Yes, that's the review
thank you.
period.
Thank you. Thanks.
Thank you for seeking clarification, Julia. Tim.
Thank you. Yeah, Julia picked up my first point, and the second one is under the board effectiveness review, item 7, where it's board committee and group meeting structures are appropriate. Can I start to do a little bit more of it's the first year we've been in that space. It'd be good to have a bit more emphasis on that in this first iteration of that, of where we've got it right and what we've learned so far.
Yeah, thanks, Tim. Richard's noted that down to take away. Tasha?
I think I'm going to build on Tim's point because on that line item or somewhere in here, I think for me, and whether we do it in group or whether we do it through the survey questions you want to ask, Richard, I think it's for you to have a think about. But I think my question was, are we set up as a board and committee structure in the best possible way to deliver our strategic objectives, and really just for us to all consider, have we got that right in terms of how we're spending our time and how we're organising ourselves to make sure that we're delivering on our requirements. So I don't know where you want to bring that out, but just to make sure that we kind of capture that strategic angle as well.
Yeah, thanks, Tasha. But Richard, I'd just say to that point, Tasha, that given that the way we constantly review, evolve, and do our work through our workshops as well, we're doing that on an ongoing basis. But Richard, I'll let you reflect on that in how we capture that as a question for going forward. Richard, let's bring you back in.
Thanks, Faisal. Yes, a great suggestion, actually. And I think rather than amending the survey question, I think the opportunity to have a discussion about this in both in the committee workshops and also board workshop probably does that best justice. And as you say, that broader consideration about are we maximising the group opportunity and also getting it right at trust level as well, I think is probably best done discursively in a workshop environment. But we will factor that in. Thank you.
Thanks, Richard. I'm not seeing any more questions. So in terms of, you've got some comments to help reshape, well, not reshape, I should say, just input and refine a little bit the process and the timetable, which we're happy with. And we endorse the proposed timetable and making a few tweaks to the approach. And we look forward to receiving the outputs from that work in due course. So thank you very much for that, Richard. And that leaves us to self-certification against the provider license, which is paper O in our pack. And this is also with you, Richard.
Thank you, Faisal. Yes, so this remains a requirement for us as a foundation trust to self-certify against the provider license, albeit we have a smaller number of self-certification requirements than we have done in previous years. The headline message is that I believe that we are compliant with this particular conditions of the provider license that are included in the template, and really just seeking board's endorsement of that so that we can then hold that on file for any future inquiry from NHS England, which is the current process. Thank you.
Thanks, Richard. And as you say, the template's appended to the report. Any questions or comments on the self-certification for Richard? No? Okay, we're happy to approve that, Richard. So you've got the sign off from board. And that moves us on to items for information, which is item 14 in your pack. You've got the declaration of interest register for 25-26. Paper P, please, that's for information. Make sure that it's regularly updated, which I know colleagues do, but just as a reminder to make sure that it's up to date. And then we've also got paper Q, which we do annually. The Director of Senior Leadership Team Gifts and Hospitality and Decoration. And this again is presented once a year for information, so everybody can see in open and transparent manner what has been received in terms of hospitality or any other gifts which are allowable within our rules and regulations. I don't think there's anything else we need to say on those, Richard. You're getting a shake. Thank you. And that brings us on to any other business. I've not been advised of anything prior to the meeting. Is there anything of any urgent nature that anybody needs to raise? No? Okay, great, thank you. Oh, Itai, sorry, I didn't see your hand come up.
Sorry, I'm just conscious I put it in the chat, but there is a typo on the monitoring workforce safeguards report. So one of the tables which has the vacancies, it's incorrect. It's actually less than what is actually written down. So we just need to amend that and resubmit the report so that we've got the accurate report for the board papers.
Okay, great. And we can make a note of that in the minutes. If you make sure that it's circulated outside of the meeting, Itai, so we've received the accurate updated report with the correct graph in there, that will be very helpful, and we can check off that action once it's been done. Thank you, Itai. Any other urgent business from anybody before move on? No? Okay. Thank you, everybody. Look, so in terms of any risks that we've picked up additional to anything that's already in our board assurance framework. I don't think I've picked up anything that we haven't already discussed. I know a couple of things that will be taken offline to follow up, which I'll leave with Richard, and hope everything in terms of the papers were all clear, very well presented. We received all papers in line with the work plan, and if there's anything we could do differently, then please do reach out to me and or Richard or Angela for that matter, and we'll pick that up. Julia.
Thank you. Just in reflection of the meeting, what a great way to start with our patient story. I held back, which is unusual for me, to let others have a chance to come in. But actually, to have the update from the Memory Assessment Service, as Natasha said, it's really important we hear the continuous improvement opportunities, you know, and actually what's happened as a result of some of that effort. But also the Oliver McGowan trainers, how fantastic. That was so good to frame our meeting and just remind us what it's all about. So just want to say thank you for a great story. It's really set us up, I think, for the rest of the meeting. Thank you.
Great. Thanks, Julie. No, would absolutely concur. And I think Angela and I were reviewing this the other day following LPT's presentation as well, that the service presentation with the staff presentation, and when you have people with lived experience and our service users and patients, it just really brings to life in a three-dimensional way for our board meeting, and really does set us up. So thank you for that, Julie. I absolutely agree with that. And as you say, closing the loop off with a previous presentation and recognizing what continuous improvement actions have taken place is always good to hear. So I think it's a great way for us to continue that. And I don't think anytime soon we'll be wanting to change that approach. So thank you very much. I'm not seeing any more comments or questions from anybody. Therefore, well, I'll propose to close the meeting. The next public board meeting of Northamptonshire Healthcare Foundation Trust is on Thursday, the 30th of July.